Thanks so much, Richard. And thanks so much for this invitation to speak at this very interesting conference. I've really enjoyed the talks by the other speakers so far this afternoon. I'm going to talk about irritable bowel syndrome. So we're actually going to move from a more general discussion of the microbiome to now talking about disease states. And what I'm going to talk to you about is a condition called the irritable bowel syndrome. And I don't have a slide on this, but I'll just say up front, IBS, remember, is I think something that we're all familiar with in this room. It's a very common condition. Probably somewhere between 10 and 15% of the Canadian population suffers with symptoms that would be compatible with this diagnosis. And remember that it's a symptom-based diagnosis. It's not a single disease. It's a condition that's defined by the presence of abdominal pain in association with altered bowel habits. And this is confusing because it can be diarrhea, constipation, or a mixture of diarrhea and constipation. And for years and years, we thought about IBS as a quote-unquote functional disorder, which means that patients have these characteristic symptoms, but we're not sure exactly why they have those characteristic symptoms. And increasingly, and the subject of our discussion today, it's becoming clear that the microbiome probably plays a very important role for at least a subset of these sufferers. Is it the explanation for all patients in IBS? Absolutely not, is what I would say. But is it an explanation for a subset of individuals with IBS? Absolutely. I think it's becoming increasingly clear that that's probably the case. So I'm going to show you actual data. We're going to talk about data that has been conducted in the last several years on this particular topic. My disclosures, the learning objectives, which are in your handout here. And I'm going to use this analogy. If you think about the potential role of the microbiome in regards to IBS, I think of it in terms of fertilizer, seed, and weed killer. And we'll talk about each of these particular areas. The fertilizer being prebiotics and food, the seed being probiotics and FMT. We won't talk about that, but we can certainly talk about that in the Q&A. And then finally, the weed killer being antibiotics. And the idea being to try to get to a healthy microbiome that hopefully can influence the natural history of disease in patients with IBS. Now, we're first going to talk about diet. Okay, and you've heard a lot about diet already and how important diet is in regards to shaping the microbiome that lives within all of us. There are a number of strategies which have been evaluated in randomized controlled trials in patients with IBS that are relevant to diet. And probably the most evidence-based strategy for IBS at the current time is something called the low FODMAP diet. FODMAP is an acronym that stands for fermentable oligo monodisaccharides and polyols, which in summary are a group of carbohydrates that are very difficult for your intestine to break down and absorb. And for that reason, these carbohydrates oftentimes make it all the way down to the colon where they can be fermented by the colonic microbiome. Now, this is by no means a fully inclusive list of carbohydrates or sugars that are included on this low FODMAP list, but this is some of the sugars that are included in this list, and it gives you an idea about how ubiquitous these FODMAPs are in a typical Western diet like you have in Canada or that we have in the United States. Now, FODMAPs, as I mentioned a moment ago, can exert effects in the GI tract in a number of different ways. So I think about it broadly in two big categories. One are direct osmotic effects. So remember that carbohydrates like fructose, for example, will exert very potent osmotic effects, direct osmotic effects within the GI tract, and lead to all of the attendant things that occur related to introducing an osmotic load. That is drawing water into the lumen and leading to a luminal distension. In addition, those carbohydrates, as I mentioned a moment ago, which get down to the colon, are fermented to produce a variety of byproducts. These byproducts consist primarily of short-chain fatty acids. We've heard about that already. And for the most part, short-chain fatty acids exert a lot of beneficial effects. The downside of short-chain fatty acids are they also create an osmotic load. And they can be fermented, or the process of fermentation also produces a variety of different gases. And so in aggregate, through those osmotic effects of the short-chain fatty acids and the production of gas, you can get an increase in intraluminal fluid content as well as luminal distension. Now here's the thing, remember that IBS patients tend to have underlying abnormalities in motor function and visceral sensation. So think about this for a minute. If you introduce a huge osmotic load into, and also create these fermentation byproducts in individuals that have underlying abnormalities with motor function and visceral sensation, it's not that far of a stretch to imagine that that will lead to the development of symptoms, unlike in an otherwise healthy individual that doesn't have those underlying physiologic problems. Now, there is data that's been recently published. There's actually 3 or 4 randomized controlled trials published this year on the low FODMAP diet. It's been said up to this point that there's really not evidence, and there are certainly problems with the quality of the evidence that exists, but more and more there's a growing body of evidence to suggest that the low FODMAP diet affects benefits in regard to symptoms in patients with IBS. This is data from our U.S. randomized control trial. This is the first randomized control trial that's been conducted in the United States. It's available online early in the American Journal of Gastroenterology, but has not been printed in the actual journal as of yet. But this is a study in around 90 patients with IBS-D who were randomized, or actually IBS-D, who were randomized to receive either the low FODMAP diet or something we call the modified NICE diet. And that is a diet based upon the NICE guidelines, which were created by the British Dietetic Association for patients with IBS. Now, the reason it's modified is because we did not exclude any foods that contained FODMAPs as part of this, of these NICE recommendations. And what you can see is for the primary outcome measure, there was a trend towards, but not a statistically significant benefit in terms of achieving adequate relief of IBS symptoms. You can see that 52% responded with low FODMAP, 41% with the modified NICE diet. What's interesting, though, is if you dive more deeply into this data and look at the individual symptoms, the cardinal symptoms of IBS, so specifically on this slide, abdominal pain and bloating, there are marked benefits offered by the low FODMAP diet compared to the modified NICE diet. And in fact, if you look at all of the recent data emerging on this topic, what's becoming more and more clear is that the low FODMAP diet is a strategy that primarily affects pain and bloating and less on bowel habits. There are effects on bowel habits, but they're not nearly as profound as the effects on pain and bloating. In addition, our study was one of the first to carefully assess quality of life. We utilized an instrument, a validated instrument called the IBS QOL instrument. And there are 2 metrics that have been utilized in literature in terms of assessing data from the IBS QOL. The minimal important response as well as a meaningful clinical response. And you can see here that there's a 2-fold greater likelihood of response by either of these metrics with the IBS QOL with the low FODMAP diet compared to the modified NICE diet. So this is data. There's also data from Steve Vanner's group. There's data from that I'll show you in just a minute from another study from the United States in children. And there's also a study from the UK that will be published in the near future, all showing very similar results to this. Now, realize that the low FODMAP diet has effects on the microbiome. There are now several studies which have documented changes in the microbiome in association with excluding FODMAPs from the diet. And that should really come as no surprise because FODMAPs are a huge category of prebiotics that we would otherwise be taking in our diets. So to exclude them is undoubtedly going to have effects on the microbiome. Now, whether these effects are good, bad, or indifferent, we don't know at the current time. One concern, one red flag that's been raised in regard to the low FODMAP diet is the fact that butyrate-producing species have been found to be reduced in at least one of the studies interrogating the microbiome. And for this reason, the authors from Australia that published one of the studies on microbiome, if you look down at the bottom, they say the functional significance and health implications of the changes that are documented with the low FODMAP diet in terms of microbiome might lead to caution about reducing FODMAP intake in the longer term. And I think it's a very important recommendation, and that is a couple things that come out of this. One is we clearly need more studies to help us to put into perspective what these changes mean, not unlike what's been alluded to by the other speakers already today. The other thing to realize is the low FODMAP strategy is not intended to be a long-term strategy for the treatment of patients with IBS. Low FODMAP is a blunt instrument to determine whether patients with IBS are FODMAP sensitive or not. If they are sensitive, they should go through a structured reintroduction of FODMAP-containing foods to allow diversification of the diet as much as possible to maintain symptom benefit. And in fact, we've been doing this now since 2008, 2009 at our center. We were the first center in the United States to start to use this strategy. I can tell you from our data that around 80% of patients who go through this structured reintroduction will be able to diversify their diet and reintroduce selected FODMAPs. The studies that we're doing right now will hopefully give us some insight into what the main drivers of response are with this diet. And the hope here is that perhaps we can make it less restrictive going forward. Perhaps we don't need to exclude all FODMAPs to achieve the same level of symptom benefit. Now, a couple other things. Think about this. It may very well be as we go forward that we'll be able to leverage the microbiome or metabolomics to identify patients more likely to respond to a low FODMAP diet. So consider this. This is a study that was conducted in 33 children from the United States, and they found that the low FODMAP diet, again, improved abdominal pain compared to a typical US childhood diet. And responders were enriched for certain taxa. So in other words, the microbiome identified characteristics that predicted a greater likelihood of response to the diet, which is fascinating when you think about the possibilities of that observation if it holds up in larger, more robust studies. Obviously, this is a very preliminary pilot study. Also, this is a study from Steve Vanner's group, which I think also gives us some very interesting things to think about. So this is a study that focused on metabolomics as a consequence of receiving either the low FODMAP diet or a high FODMAP diet. So this study from Canada, again, showed benefits of a low FODMAP diet compared to a high FODMAP diet, and very interestingly, changes in metabolomic profile in individuals on the low FODMAP diet versus the high FODMAP diet. Now, even more interestingly was this observation. One of the main drivers of those differences in metabolomic profiles was histamine. So they actually they collected urine samples and did urinary metabolomics, and they found that urinary histamine levels dramatically dropped in FODMAP responders, suggesting that there may be anti-inflammatory effects associated with the low FODMAP diet. This is obviously very, very preliminary, but it's an interesting insight, and it also gives us insight into this possibility of perhaps leveraging metabolomics in a way that allows us to identify individuals that are more likely to respond. All right, how about prebiotics? Well, I think we're all very familiar with what prebiotics are, but interestingly, remember that one of the main sources of prebiotics in our diet are actually FODMAPs. We have no high-quality randomized controlled trials right now which have evaluated prebiotics as a treatment for patients with IBS. Remember, though, that fiber is a very important prebiotic that's, again, been alluded to by some of the other speakers. And not all fiber is created the same in regards to the management of patients with IBS. The reason I say that is because in a recent meta-analysis that was published by Alex Ford and colleagues, he actually reported that bran, so insoluble fiber, i.e. bran, led to very different outcomes in patients with IBS compared to soluble fiber, in this case, psyllium or isbagula husk. So in their analysis, they actually found that while Ispagula husk or psyllium led to benefits in overall IBS symptoms, bran did not achieve the same level of success as a treatment for patients with IBS. And that's why the American College of Gastroenterology Task Force made these statements on the bottom. Specifically, psyllium but not bran provides overall symptom relief in IBS. Now, I also wanted to make this comment, because another very interesting thing on the horizon is the idea of using foods or food constituents as a means of manipulating the microbiome in ways that potentially could be beneficial to the human host. So this is actually data from a very interesting study that was conducted by one of my colleagues, the head of the Microbiome Project at the University of Michigan, Tom Schmidt. Tom actually has an undergraduate course where he teaches students about the microbiome, and as part of this course, the students actually participate as participants in a human trial. And so this trial was actually intended to look at the consequences of supplementing the diet with resistant starch to see if you could increase excretion of butyrate in stool. And in fact, what he found was that after X number of days of fairly large doses of resistant starch, that there were, on a population basis in these University of Michigan undergraduates, a significant increase in fecal butyrate excretion. But a couple things to also note about this that are really interesting. The first thing is, if you look across here, while there is clearly an increase in mean butyrate excretion, not everybody got an increase in butyrate excretion. In fact, some of the individuals, you'll notice, had no change. Some of the individuals, a small number, actually had a decrease in fecal butyrate excretion. And the point being this, is that there's a tremendous amount of inter-individual variability in regard to the responses to things like prebiotics, for example. All right, let's talk about probiotics. And of course, probiotics can exert benefits for patients with IBS in a variety of different ways. They can interfere with growth and survival of bacteria at a luminal level. They can have mucosal effects on barrier function, as well as a mucosal immune system, and that can translate to, at least theoretically, systemic immune effects. The U.S. probiotic market, very similar to the Canadian probiotic market, is growing. In fact, I'm not going to belabor this point, but suffice it to say that if probiotics were a pharmaceutical, this probiotics would actually be considered a blockbuster. This is a multi-billion-dollar industry and growing in the United States. Now, realize that probiotics overall appear to offer some benefit for patients with IBS. So in this meta-analysis, again by Alex Ford and colleagues, where they looked at a very large number of randomized controlled trials which have evaluated different probiotic supplements in patients with IBS, bottom line here is that probiotics did better than placebo in patients with IBS. But, and this is a very important proviso, unfortunately, the quality of evidence was not at a point at which these authors felt like they could make recommendations for individual probiotic supplements. I would point out, though, that one pretty striking thing about probiotics is the number needed to harm. You know, on the bottom there, you can see the number needed to harm was 35. That means that you'd have to give 35 individuals a probiotic to see one potentially significant adverse outcome. So overall, they looked very safe within this analysis. Probably the most evidence-based probiotic supplements that we have for IBS right now are Bifidobacter infantis 35624, actually 2 randomized controlled trials which have evaluated this probiotic supplement in patients with IBS. This is one showing normalization of serum cytokine levels as well as improvement in IBS symptoms. Another one from Europe showing benefits for overall IBS symptoms at one of the doses compared to placebo. I wanted to just mention this point, though. And this is a very interesting study. Because, and if you look at this, so this was another randomized controlled trial looking at a multi-species probiotic supplement versus placebo in patients with IBS. And if you look at this, if you look at week 8 and look at week 12, when you first look at this, you say, wow, that probiotic worked really well. But look at the legend. So here's the interesting thing. In this trial, placebo did a lot better than the probiotic. And I think it speaks to this point again, that we have a lot to learn, and not all probiotics are going to be appropriate for every disease state. There is data that's been published. Actually, this is an analysis from a Canadian group that talked about a variety of different commercially available supplements for which there is evidence for IBS. There are actually 3 listed out here on this slide. The print's a little bit small. I apologize for that. This is a little bit easier to read. This is actually analysis from a group of experts that get together at Yale every other year and talk about the data relevant to probiotics for a variety of different disease states. This is their analysis for IBS. They said that there was data for Bifidobacter infantis 35624 and VSL number 3. They gave it a moderate quality of data analysis. And for Bif animalis, which is, of course, the probiotic in a certain type of commercially available yogurt, as well as Lactobacillus plantarum 299V, there was also lower quality data available. So we'll finish up by just a couple comments about antibiotics, and this is an interesting discussion on the heels of the topics which have been discussed previously. But realize that there are now a large number of randomized controlled trials which have evaluated the benefits of rifaximin, a poorly absorbed oral broad-spectrum antibiotic, versus placebo in patients with IBS. This is data from the Target 1 and 2 trial, which were published in the New England Journal of Medicine several years ago by Mark Pimentel, myself, and others. These were very large, high-quality randomized controlled trials evaluating rifaximin, 550 milligrams TID, versus placebo for 14 days. You can see statistically significant benefits. A recent meta-analysis that we published on this topic evaluating 5 different randomized controlled trials looking at rifaximin versus placebo reported a therapeutic gain of around 9% with rifaximin versus placebo, so a number needed to treat of around 11. Also for bloating, similar therapeutic gain, a number needed to treat. And I'm going to skip through for the sake of time to here, because I think at this point the data is clear. There are a small subset of IBS sufferers that seem to get better when you treat them with rifaximin, but the benefits appear to be transient. And a very important point is we don't know why this works for some of these patients. Whether it's related to treating bacterial contamination of the small bowel or somehow altering the colonic microbiome, we really don't know why this works at the current time. If it is related to small intestinal bacterial overgrowth, as some have suggested, we don't have a reliable means of identifying patients with that condition at the current time. Breath testing is available, but highly flawed. So to summarize, agents that influence the gut microbiota offer a potential target in patients with IBS. Specific probiotics may improve IBS symptoms in a subset of patients. Prebiotics remain to be adequately tested in clinical trials. Antibiotics offer short-term benefits to a subset of patients with IBS. And I think a really important question, lots of important questions remain, but one really important question is, who are the patients that will respond to these strategies? I mean, it is, I think, it's a little bit frightening to think about giving big populations of individuals, for example, antibiotics to treat IBS. But I think that going forward, there's the opportunity to be able to leverage a microbiome, metabolomics, other perhaps serum-based markers to identify patients that are more likely to respond to this strategy. So at the end of the day, biomarker-based strategies are going to be important to maximize benefits. Thank you.
Short, please.
Any additional advice in patients where you suspect SIBO, aside from testing for nutrient malabsorption and recent procedural history? Anything else you could suggest in terms of antibiotic or probiotic use in those patients, or how to approach them in general, since there's no good testing for bacterial overgrowth in the small intestine?
I'm not sure.
Small bowel intestine, bacterial overgrowth and dysfunction.
Thank you.
Gotcha. So you were asking about SIBO. I'm sorry, I couldn't
Yeah,
understand.
so use, I guess, just what to do in general in patients who are suspected to have SIBO.
Gotcha.
In terms of determining probiotic, antibiotic use.
It's a huge problem right now, again, because a lot of people don't have access to breath testing, and as I mentioned a moment ago, we could literally have a half an hour discussion about the problems with breath testing. In fact, all of the studies, for example, with rifaximin, have not utilized any biomarkers. They're all the data that I showed you is all empiric treatment with rifaximin. I think that when you have a high pretest probability of bacterial overgrowth, that should be high on your differential, and treatment for bacterial overgrowth should be high on your differential. So for example, these types, or complaints like bloating, abdominal pain, diarrhea in a diabetic or a patient with scleroderma, for example, there's a very, very high likelihood of bacterial overgrowth. In fact, to the point where you probably don't even need to test, you can just treat. Okay, one of the things I found very interesting about the comments made by one of the earlier speakers, though, was this whole issue about where the cut point is, where you're starting to make irreversible changes with regards to treating with drugs like, for example, Cipro or other quinolones. I think that's something that we need to start thinking about, and we need to study. Right now, I'm not aware of any data actually in that regard.
Thank you.
Well, thanks very much, Bill. And